Now we'll move on to another important session. That's male genital dermatosis. For this, I invite the session coordinator, Dr. S.B. Kavita. So please go ahead with your talk.
A pleasant good morning to all the ASTICON 21 organizing committee members and all the delegates who are participating today. And the theme for today, Man Ki Baat Dr. Ke Saath of STIs and AIDS. So the second session is going to start now, which is mostly on male genital dermatosis. And the chairpersons for this session are Dr. Rajiv Sridharan sir, Dr. Vineet Rilhan, Dr. N. Ramesh sir. So kindly take your seat, sir. I now request Dr. Rajiv Sridharan sir. Kindly display the sir's CV, please. So Dr. Rajiv Sridharan sir, he is the Vice Principal and HOD Dermatology, who has publications of around 24 with 20 presentations, and he is the President of IDVL Kerala, for which he received Best Branch Award, and he has actually he's an IDVL President Appreciation Award in 2018, and he's also IDVL Academy member and Damagyan coordinator in the year 2017. And his areas of interest are in the field of clinical dermatology as well as in venereology. Dr. Vineet Rilhan sir, Dr. N. Ramesh sir, he is the President-elect of IDVL Telangana 2021, and he is the Chief Staff Surgeon and PHOD of Central Hospital, South Central Railway in Hyderabad. Dr. Vineet Rilhan sir, he is actually a professor of Maulana Azad Medical College. He has a lot of publications and presentations, and the awards and honors and achievements. He is the National President of IDVL, and he received IDVL Appreciation Award in 2015. And he is an organizing president of North India and PGCon 2017. And his areas of interest are in the field of clinical dermatology of STIs and dermatosurgery. I kindly request our chairpersons to introduce our speakers. Dr. Sumati Muralidharan, the first speaker of this session.
Thank you, Dr. Kavita, for those nice words of introduction. And on behalf of all the three chairpersons, I take this opportunity to thank Team Telangana, especially Dr. Bhumish, for giving us this opportunity and for this wonderful conference. I had the pleasure of introducing the first speaker, Dr. Sumati Muralidharan. Basically, she is a microbiologist and also did her diploma in STD AIDS from Bangkok, Thailand. She's a professor and consultant microbiologist, presently working in VMCC and Saptajang Hospital. She is a nodal officer for State Referral Laboratory. She is a member of many technical teams and editor of South Asian edition of the textbook of microbiology. So we are going to have the first speaker speaking to us today. Over to you, madam. The floor is yours.
Thank you, sir. I'm sorry I couldn't get this background of the ASTICON in my system. Yeah. Good morning, everybody. I bring you greetings.
Ma'am, switch to a slideshow.
Yeah, I have. Yeah. Is it okay now?
Yeah. Yes, yes.
Yeah, good morning, everybody. I bring you greetings from the Vardhaman Mahavir Medical College and Saptajang Hospital in New Delhi, where I work as a professor and consultant microbiologist. And at the outset, I'm thankful to the chairpersons for inviting me to speak today. And I'm extremely thankful to the organizers for inviting me to speak at this mega event, which has been beautifully organized. And another round of thanks is for the important topic that's been given to me, the importance of investigations to detect extragenital STIs, which is an oft neglected topic. Now, what are extragenital STIs? These are nothing but sexually transmitted infections which are manifest beyond the genital tract. And when we say beyond the genital tract, what does it include? The genital tract includes mostly the urethra, cervix, and vagina in females and the urethra in males. So beyond anything that is beyond the genital tract is considered extragenital. For example, rectum and pharynx, which are most common. But apart from that, you can have the conjunctiva, the lymph nodes, that is the bubo, skin lesions, etc. Apart from this, There are some diseases which are sexually transmitted, such as hepatitis A, B, C, and HPV infections, which are sexually transmitted, but they manifest in other parts of the body. So the importance of these extragenital STIs are that they serve as hidden reservoirs because they often go undetected, and yet they play a very critical role in STI transmission and also in HIV infections. Apart from that, optimal screening strategies for these infections are usually deficient in most labs. And they have implications beyond the STI because a person with an extragenital lesion would often go to maybe a general practitioner or somebody else and waste their time that way and then come to the STI clinics. It could be misdiagnosed. And here the laboratories play a very important role. And another important aspect is that the treatment for these extragenital STIs may be different from genital STIs. There are two examples I have cited here. Studies have shown that the pharyngeal gonorrhea, I use the word GC for gonorrhea and CT for chlamydia trachomatis, that is chlamydiasis. So pharyngeal gonorrhea is said to be better treated with ceftriaxone injections rather than oral cefixime, which is usually done for the genital gonorrhea. And for rectal chlamydiasis, doxycycline is said to be far better than azithromycin. So studies have shown this. So the treatment could be different in an extragenital STI. That makes it very important to diagnose them. And they are increasingly occurring in some key populations and high-risk groups. And more importantly, the antimicrobial resistant isolates are more common among these infections. So for all of us as healthcare providers, if we are screening and testing only the genital sites for these infections, then we must know that we will be missing about 73.8% of pharyngeal gonorrhea, 71.8% of rectal gonorrhea, and about 88.3% of rectal chlamydiasis, which is very significant. Now, coming to the global scenario, a few words about what the scene is like about in the extragenital STIs. So GC and CT are on the rise, especially among the MSMs, as per a CDC analysis in 2019. And 92% of pharyngeal gonorrhea is asymptomatic, and so also about 84 to 86% of rectal gonorrhea is asymptomatic. And rectal gonorrhea, the incidence is about 0.6 to 35.8%, and the range for pharyngeal gonorrhea is 0 to 29%. Rectal chlamydiasis, 2 to 77.3%, that's a wide range, and pharyngeal chlamydiasis, 0.2 to 3.2%. And it's also known from studies that in men, only 14% of chlamydiasis are symptomatic, and only about 40% of gonorrhea are symptomatic, which means there is a large chunk of asymptomatic infections which we have to catch. And another important finding is that 30% of symptomatic gonococcal urethritis is attributed to oropharyngeal exposure. So what do? We have to screen for the extragenital STIs. So how do we screen? Screening means testing for STIs at specific sites of sexual contact. It is often the butt and the throat, that is the rectum and the throat, but it could be any other site also. And there is now a growing need for routine extragenital screening, which we have started in our department also about a year now. And screening of key populations is also very important. But there are several barriers to these screening. Patient-related barriers, such as patients may want frequent, convenient, and affordable testing, which have to be arranged for. And provider-related issues include the knowledge, time, and comfort of the provider, that is the clinicians, because they have to elicit a complete sexual history and perform a thorough and complete physical examination to detect these extragenital sites. And also system barriers such as the cost of testing and some of the laboratory issues like the NATs and the kits which may not be approved. So you have to do a validation of the tests before you apply them for diagnosis. So lab diagnosis of extragenital STIs, what are the facilities available to us? CDC recommends that most of these should be tested by NAT. NAT is nucleic acid amplification tests. So these are the ones which are more sensitive, and they are specific also. And many of them are now FDA approved. That is, you have FDA approved kits for many of the extragenital STIs. Sorry, the genital STIs like gonorrhea and chlamydia, you do have a lot of FDA approved kits, but for extragenital sites, they were not approved. But the good news is that as of May 23, 2019, the FDA has cleared 2 kits which are for NAT testing of gonorrhea and chlamydia from extragenital sites, that is from pharynx and rectum. So this is just a list of all the kits that are available for the NAT testing of CT and NG. So we also have the POCTs now, that is the point of care tests. You know, now all the clinicians as well as patients, everybody wants quick results. Sample in, result out. That's how they want it. So the laboratory and research has provided these point of care tests where the results are available very quickly. That is in a matter of about 20 to 30 minutes. And most of these kits are pretty specific and sensitive too. And the other big advantage is that many of these kits can be used for multiple STI diagnosis. So for example, you have kits which can detect CT, NG, TB, that is Trichomonas vaginalis, and Mycoplasma, all of them in one kit. So this is the advantage of the POCTs, and we have several of them in the pipeline now. So what are the samples to be collected for extragenital STIs? The anorectal swabs, oropharyngeal swabs, urine first voided, conjunctival swab, and material from the buboes or the lymph nodes, and other extragenital lesions such as the skin lesions, etc. So coming specifically to certain STIs which are important. In gonorrhea, you must remember the oropharynx is a very critical site for the emergence of antimicrobial resistant Neisseria gonorrhoeae. And also when you are testing the extragenital sites in men and women both, remember the gram stain is not recommended for pharyngeal and rectal sites for obvious reasons because of the commensals. So routine screening should usually include only the NAT, that is the nucleic acid amplification tests. When it comes to chlamydia trachomatis, in women, extragenital sites are not done routinely. It is still not a rule to test. And whereas in men, extragenital sites are being tested, especially in high-risk groups. And they have found that the self-collected swabs are as good as the clinician-collected swabs. So that is a very important thing, and which makes it easier for the diagnosis. And for lymphogranuloma venereum, diagnosis is usually based on clinical suspicion or local epidemiological data, or by ruling out other STIs. But here again, extragenital sites can be involved. So anogenital swabs can be taken or lymph node specimens. And what you can do with this for diagnosis is culture, direct immunofluorescence, or you can use the NAT. NAT is to be preferred now for detecting this. But please remember, most of the commercial NATs, they do not identify the chlamydia trachomatis of L1, L2, L3. That is the ones causing LGV. So you have to have a NAT which is specific for LGV. Now you do have real-time quadruplex PCR-based assays where LGV can be diagnosed. But unfortunately, these are not yet FDA approved. So this is just to summarize the tests that are used for chlamydial detection. So of all the tests, you can see that NAT, that is nucleic acid tests, are the most, are the best, and they are the most sensitive. So for syphilis, since I'm dealing with the extragenital lesions, in primary syphilis, you can get the chancre on extragenital sites like the fingers or the oral lesions. In secondary syphilis, you can get the rash on the body, any part of the body. And you could also get the condyloma lata in the folds of the anus, gluteal region, gluteal folds, anus, and other non-genital sites. As far as chancroid is concerned, especially in persons with HIV, extragenital involvement is quite common here. It could involve the thigh, the anus, abdomen, hands, breast, mouth, etc. And the definitive diagnosis here in chancroid is by culture. You use specialized media for culture because there are no FDA-approved PCR tests available for H. ducreyi as of now. But believe me, culture again is very difficult because we have been doing it in our laboratory, culture for chancroid using the specialized media for over about 18 years, and the results are not really that promising. I mean, we've not got much of a success here. It is difficult because culture itself is even said to be just 50% or less sensitivity. And as far as HSV is concerned, earlier we used to conventionally say that HSV1 causes lesions above the belt and HSV2 below the belt. But now we do know that both HSV1 and 2 can cause genital infections and lesions anywhere.
Dr. Sumati, we are 3 minutes away from schedule.
Yeah. So the extragenital lesions can occur elsewhere. So the DNA PCR is the one to be tested for this. For HPV, again, extragenital lesions could be anal specimens. And in HIV, you should screen for all diseases, all STIs at extragenital sites. So some of the high-risk groups, like CDC has recommended that MSM is a high-risk group. So here, apart from clinic attendees, you have to test in asymptomatic extragenital STDs in MSM groups. And these are the sites you have to test: pharyngeal, rectal for GT as well as for CT. And here they have given a very good format where it says it's a self-testing format for MSMs, which could be adopted by other countries, where it says, do you provide oral sex? If yes, please swab your throat. And if you're an insertive partner in anal sex or oral sex, give your urine sample. And if you are a receiving partner in anal sex, you give your swab, rectal swab. So, and these are all for self-testing. It's all pictorially demonstrated and extremely clear. Transgenders, again, we must remember that their anatomy and sexual practices are very important to take into account, because even if it's a transgender male, they could have a vagina, cervix, etc., and have infections. So if the person is on pre-exposure prophylaxis for HIV, again, extragenital screening should be done in high-risk groups at least once in 3 months. So what about the ladies? We shouldn't forget that women also can have extragenital STIs, especially because they are oral and anal receptive intercourse they do indulge in. And these are not usually recommended as of now, but they should be thought of. And we have to ask the history. And if they are at risk, one has to perform tests for them also. And please do not forget partner notification and rescreening and retesting after the treatment. This again is important. Here, expedited partner therapy is being followed in some states in USA, where they give the treatment to the partners even without their presence. But of course, there are repercussions to this, but it has prevented recurrent chlamydial and gonococcal infections. Now, since I'm from the laboratory, a few words on the laboratory. Diagnostics and laboratories are often undervalued, and they are as important as the medicines and vaccines given. And a large proportion of these extragenital infections are asymptomatic. So that's where the laboratory comes into play, because screening and early diagnosis is very important. And for this, we have a whole lot of point of care tests for you to use, which can be done in patient single visit, and as well as it can be helpful in surveillance purposes, and it can be used in all levels of the healthcare system. So that is the importance of the laboratory for these, especially extragenital infections. So make extragenital testing a priority and take good charge, and that is at least 3 sites: rectal, pharyngeal, and apart from your genital sites, we have to do it at least annually or once in 3 months or 6 months if indicated in high-risk groups. So that's my message for you. Thank you for your attention, and thank you to the organizers for giving me this opportunity again. Thank you very much.
Thank you so much, ma'am, for enlightening us on this topic on the investigations to detect extragenital STIs. It was really an excellent session. I now request Dr. Vineet Relhan sir to introduce our next speaker, Dr. G. Narasimharao Neta sir, who speaks on circumcision, boon or bane.
Yeah, good morning to all of you. At the outset, I want to place on record my thanks to Team ASTICON for making me a part of this prestigious event. And the next speaker is Dr. G. Narasimharao Neta. Sir is a professor and HOD at Gandhi Medical College, Secunderabad. Sir has 13 publications and 20 presentations. He was a past president of Telangana State Branch, 2019. Sir was former secretary of Telangana State Branch 2016, and the areas of interest are dermatosurgery. In the next 15 minutes, sir will be talking about a very important topic: circumcision, bane or boon. Over to you, Dr. Netha, sir. Hello. Please share your screen, sir.
Vinirji is sharing.
Okay, sir. Okay.
Netha sir, unmute yourself. Unmute yourself. ముందు ఓపెన్ చేసుకొని పెట్టుకోవాను.
Thank you for kind words. I have been given to talk on circumcision, bone or bane. On regarding the circumcision, as you all know, male circumcision taken from a Latin word, that is circumcidere, that mean by to cut around. It is defined as the surgical removal of the foreskin from the human penis. You can see the normal penis with foreskin. In divide of the foreskin in the circumcised penis, you can observe here. Regarding the prevalence of the circumcision, as per the WHO estimated in 2007, they says that around 1/3 of the global population has been circumcised. So that prevalence, we can understand how much it is been done circumcision. So regarding the history of the circumcision, this procedure has been practiced by the ancient Egyptians, then by certain religious groups like Jews and Muslims. You can see a photograph here. In Jews, circumcision is a part of the Brit Milah ritual to be performed by the specialist ritual circumcisers, called Mohel, on the day of the 8th day of the newborn child. It is also called Ketan. It is practiced nearly universally by the Muslim males. For Muslims, circumcision is a matter of cleanliness, purification, control over one's baser self, nafs. You can see the photograph here. If you talk about the indications of the circumcision, as a routine indications, as you all know, really on the basis of the religious beliefs. In medical indications like phimosis, melanoposthitis, in recurrent urinary tract infections, and also indicated in limited HPV, HSV conditions. Also, as part of the treatment in vesico-urethral reflex, neonatal hydronephrosis, and the posterior urethral valve conditions. And also indicated in paraphimosis in case of tear, when the sexual intercourse leads to severe bleeding. Those conditions also requires for the circumcision, and melanoposthitis, recurrent melanoposthitis. Those conditions is need to be go for the circumcision. Regarding the contraindications for circumcision, any genital structure abnormalities, anatomical abnormalities like hypospadiasis, epispadiasis, and ambiguous genitalia, these conditions will never be done any circumcision on the penis. Technique of the circumcision, it is a simple basic removal of the foreskin. In that can be done in neonates, infants, adults, adolescents, and old males population. Regarding the discussion of the doing the infants, certain devices has been practiced by using the Gamco clamp, Plastibell, and the Gogan clamp is commonly being used in USA. This is all of you know, circumcision is being done by some trained persons in as well as by the urologist, in general by general surgeon, and who is trained for the circumcision. Technique of the circumcision: first thing you have to see the how much skin to be removed, you have to assess. Then inner lining of the foreskin is separated from the glands. Then the foreskin of the remaining skin part is removed and stitches and given to the mucosa from the skin. To see for the bleeding should not be taken place. Hemostasis must be maintained. Sometimes they used to practice certain procedure called the plastipel technique. In that plastipel technique, what they used to do is dorsal slit they make on the dorsum of the penis and separate the foreskin and keep the plastipel instrument over the glans penis and tight over the foreskin over that, and the excess skin is trimmed off and leave it for 3 days that is fallen off. That is the procedure being practiced in some centers. What is the bone due to the circumcision? We have to understand. As per the study says, HIV infection risks by male who is practicing heterosexual sex is reduced by around 50% of the occurrence of the risk of the HIV infection. We can dramatically change, we can observe after the circumcision. Regarding the risk of recurrent urinary tract infections in the first year of life in male infants can be drastically reduced. In a circumcised male, you can see photograph here. Estimated in uncircumcised male is 14 out of 1,000 infants, whereas in estimated 2 in per 1,000 in circumcised male infants. Circumcision decreases the incidence of febrile UTI, urinary tract infection, especially in the first 6 months of the life. Neonatal male circumcision has been proved prevention of infant urinary tract infections like in the form of myotitis, peritonitis, phimosis, and protection from the viral STI and other form of the STI. The protection effect of the childhood or adolescents circumcision is definitely protective effect in the invasive penile cancer by the form of protecting from preventing the phimosis of the penis. Increased risk of cancer is related to phimosis, which can be the result of poor penile hygiene, as we all know that. It reduces the incidence of penile cancer indirectly by decreasing the chance of phimosis. The risk factor for penile cancer is phimosis, as we all know. Neonatal circumcision is more protective against penile cancer compared to circumcision performed at an older age group. Male circumcision has been shown to reduce the risk of other STIs, that is, has been proved. 2 trials demonstrated reduces the risk of acquiring genital herpes by 28 to 34%. And the risk of developing genital ulcerations by 47%. Other trials found reduces the risk of oncogenic high-risk human papillomavirus by 32 to 35%. The risk of bacterial vaginosis was reduced by 40%. The risk of trichomoniasis was reduced by 48%. The neonatal male circumcision in United States, they projected and highlighted that increased quality adjusted life years and cost saving due to reduced HIV infections and the treatment costs. The circumcised men reported increased penile sensitivity and enhanced ease of reaching the orgasm. Another study says 97% of female partners reported either no change or improved sexual satisfaction with male partner who has been circumcised. Bane, due to circumcision, I would like to emphasize. Some people believe foreskin serves as a vital purpose and protects to the penis altogether. Several problems we can they emphasize that foreskin is a very sensitive, and after removal, it leads to decrease in sensitivity near the tip of the penis. So this could affect the man's overall sexual satisfaction. As we all know, any surgical procedure may give some sort of complications like urethral stricture may be encountered. They presume that, they say that removal of the foreskin may lead to irritation of the tip of the penis, may ultimately lead to urethral stricture. They depend like that. Surgical complications. Any surgery may lead to some sort of complications may encountered, that we have to prepare and give the treatment appropriately. In this case, circumcision, we can encounter urinary retention is a common problem due to the pain after the surgical procedure. And bleeding and infection is a common. This has been occurred 1 in 10 to 1 in 50 of the chances of the cases. And also due to poor technique, may develop urethral injury, leads to concealed penis, phimosis, and urethra may occur rarely, urethroputaneous fistulas, and excessive skin removal may happen due to poor technique, may rarely seen inclusion cysts, and very rarely hypertrophic scar or keloid formation may encounter. All these complications can be minimized. Can be minimized to less than 1% by doing trained practitioners and by following the sterile settings, and with proper follow, we can minimize up to the less than 1% of the complications. Some anecdotal report says that male circumcision.
Dr. Mehta, we are 3 minutes away from schedule.
Male circumcision can cause sexual dysfunction. Take home message: circumcision induces the chance of acquiring transmission of HIV and other sexual transmitted infections. Neonatal circumcision has been shown to have a protective effect against UTI, especially in the first 6 months of life. This is considered as an act of hygienic practice. So it has few cons like reduced sexual pleasure and lack of protection to glans penis and injury to meatal opening. It is considered as a boon, but not definitely a bane. With this, I conclude. Thank you one and all. Thank you very much.
Thank you so much, sir, for throwing light on the circumcision. It's definitely a boon, but not a bane. I now request our chairperson, Dr. N. Ramesh, sir, to introduce our moderator, Dr. Rajiv Singh, sir, for the panel discussion. Topic: tips and tricks in the management of non-STIs and STI.
Good morning and greetings to all the delegates. Dr. Rajiv Singh has been very active in Telangana State dermatology activities, and he has been a very sincere and dedicated member of the community, very seriously involved in effective transmission of knowledge in the management of DBL, particularly to the postgraduate students and the junior practitioners. So he is right now the professor at our department in Usmania Medical College. He has several publications to his credit, and he awards and honors he had received plenty in the last 6 years since the Telangana state was separated from combined state. And he had also served the TS IIDL as Honorary General Secretary in 2018-19. So his areas of interest include dermatosurgery. Now I request Dr. T. Rajiv Singh to go ahead with his moderation. Over to Dr. T.
Thank you, Dr. Ramesh, sir. You have been kind enough in speaking a few words as regards me. Yes, I was truly involved with Telangana activities right through from the inception of Telangana, which got alienated from erstwhile AP state. I thank my organizing chairman, Dr. Narasimha Rao Neta sir, Bhumesh Kumar, my colleague, Venkatrana sir, my professor, P. Narasimha Rao sir, my scientific chairperson of this organizing committee, along with myself, having tipped me for this trickish male dermatosis chapter. I welcome Dr. Jaydev Betkarur sir, who is now the present national president. I know sir is very busy. Just now I have seen that in the ascent he has given his presidential speech and has come back. He has all this to his credentials, Jaydev Betkarur. Very sincere, very sincere, very hardworking personality. Thanks sir to be with us with this Telangana ASTICON organizing committee as a panelist in my panel. Thank you, Thapa sir. Thapa sir is well known all over nation. He's a national figure, and thank you, sir. He has his credentials, which is displayed here. Thapa sir has been all along good. Rashmikant Shah, sir, is a private practitioner at Mumbai and a very eminent dermatovenerologist. Has been the display is on for all of you. He has been 10. Yeah. Then Ilangavan sir, yesterday he was very busy in that Kerala ASTICON, and then sir called me yesterday that I am busy. Raj, what is the schedule? Let me tell you, this is all an open discussion. It is a thrilling discussion. It will be an open discussion. These panelists, this Sivaram Reddy sir has been so simple. See, one sentence will picturize him that he is a very simple and a modest person. Right through, he was my colleague in Osmania Medical College. He was senior to me as an associate professor. Now I have moved on Padma. This is my colleague as well in Gandhi Medical College. I welcome all the people herein to concentrate on this. Now the panelists will discuss on this issue of 21-year-old male patient, known case of RVD. Since 8 years of age, came with these lesions. Patient denied any sexual activity. What would be the provisional diagnosis and what would be the differential diagnosis in this situation of a very thrilling picture? I request all to concentrate on this, because this is not a tailor-made, please. It is for the first time that the panelists are seeing, and that's an open discussion.
Sir, I think it could be molluscum or something like cryptococcal infection generalized, or probably histoplasmosis.
Excellent,
this could be one of the few. And this patient could be possibly immunocompromised. His HIV test has been done or not, I do not know, but that could be. Adult patient with molluscum is unusual.
True, sir. Yes. Sivaram Reddy, sir.
The site of lesions look like molluscum contagiosum. Probably he's an immunocompromised patient. If some more history can,
Good, sir. We'll project shortly. As of now, this picture depicts these two things. One is molluscum contagion, the other lesion on the shaft of the penis, sir. If you people can concentrate.
That is, HPV infection. It looks like genital wart.
Yes, sir. Yes. Anything more, sir? Yes, sir.
Because patient is on antiretroviral therapy and immunocompromised.
Correct.
I think the morphological picture is changed.
Yes, Sivaram Reddy, sir. Now, please see the other part. Patient was on irregular treatment with ART. Started taking ART. Yes, sir. Yes, sir.
Sometimes both lesions can be there, Dr. Raju.
Yes. Umesh, could you please move the slide further, please? Up.
Rajiv, I don't know how long it is the disease has been there.
Correct.
Both the conditions have been there for 8 years, or one?
Correct, sir. When he was at he acquired this infection when he was 8 years age, and then
8 years of age.
Of late, they started only after having used ART. These lesions cropped up.
Correct.
The patient.
So no. Which of these, the lesions on the shaft came first, or the lesions on the thighs?
Simultaneously, he says. At the age of 8 years. 8
That
years.
means he's
Yes.
been having it for last
2 months.
15 years.
Yes. 2 to 3 months he had. Once he started ART, then subsequent to 1 month of having taken ART.
No, I'm not getting this. You say
Yes.
he is since 8 years of age. That means he has been
He
having it
developed
for the last
RVD, correct? He was
15 years.
positive when he was 8 years of age.
Okay, but the
He's an
lesions are only
orphan.
2 to 3 months.
He was on irregular treatment. This very clearly written, sir. Patient was on irregular treatment with ART and started taking ART continuously for the past 2 months.
Okay. The lesions are only for 3 months.
Yes, sir.
All the lesions.
Yes, sir.
Sir, can I interfere? I'm Dr. Ilango.
Yes, sir. Please.
Yeah. The thing is, the lesions are the past 3 months after starting the ART continuously.
Correct.
Yeah, then that situation.
That's what I wanted.
The subclinical.
Yes, sir. Truly. Yes.
Subclinical has become clinical, and we have got the lesions like this.
Yes.
Most probably, iris may be the reason.
Correct. Perfect, sir. True. You have hit the nail
That's
right.
what I was thinking about. Iris.
Yes, sir. But Karur, sir, yes.
My question is whether the HIV infection has been acquired congenitally.
No, not congenital. He is not clear about that. He says he was diagnosed when he was at the age of 8 years. He was diagnosed of having a HIV disease. That's what he said when he came.
Sexual assault at the childhood.
No, sir. Never he uttered anything of that sort. He said, I just acquired infection this way. That's all. And I was diagnosed with this. He never said that I had any history of exposure and all. Never. We tried in that fact, but he never revealed that. But incidentally diagnosed as positive.
No point in inquiring the 8-year-old.
Blood transfusion?
Not possible.
Not sure, sir, but that is how he came to the OPD.
So in children, we always suspect sexual assault. It might have happened 3 years or 4 years ago.
Maybe true, sir. Yes, it is very open. It is an open fact that must have occurred. Yes.
Dr. Raju,
yes,
I think that this patient at the age of 13 years itself is having some lesions on the genital area.
Yes, sir.
That is 8 years back.
No, not 8 years back. 8 years back, he acquired infection.
What we are, see, I'll just clarify. I think the whole thing is this patient was diagnosed to have HIV when at the age of 8 years. He is on irregular ART. Since last 3 months, he has developed all these skin lesions. And for last 2 months, he has been taking ART continuously.
That is the scenario.
The gist of this case. Yes?
Yes, sir. That is the scenario.
Yes. So what Elangovan is telling that it could be iris, it could be iris also. Yes. Probably he is now going into iris because the florid lesions. The other diagnosis which was projected here is that bovinoid papulosis on the genitals. This could be a possibility, especially on the shaft of the penis. So my approach would be in this case, since he is a known retropositive, so there is no need to investigate him further on that aspect of it. Since he is already on ART, I don't think we need to do anything more on part of it. Hopefully the ART is good, and he only counseling regarding the continuation of the treatment is very much necessary. The second part, I think I would, because he's got very florid lesions, I would take a biopsy from the shaft of the penis, one lesion, for confirming whether it is bovinoid papulosis or a wart. We need to confirm that. And
yes, sir. We had a
the second
done.
one, I would just put a needle and see what material comes out from the molluscum lesions. As far as my experience goes, if the ART is continued further, the molluscum lesions may disappear on their own. And at the most, instead of going for anything else, we could try KOH on these lesions. Simpler thing would be just potassium hydroxide on these lesions. And depending on the report, biopsy report, we go ahead in the management of the lesions on the shaft of the penis. If they are bovinoid papulosis, then it becomes a bit difficult to treat these guys. So, and if it is wart also, it is a bit difficult to manage this case. That is what probably the way I would approach this case.
Excellent, sir. Excellent message. Excellent message. Sir, anything else? Any of the panelists would like to give their
See the
suggestions? Yes, sir.
CD4, whether it is very low and whether it is effective or not. Is there the drugs are effective or not? So that thing we have to see after a matter of 6 months only. So you have to see the viral load, whether the viral load is very high, whether it is the 4th stage or 3rd stage.
Yes.
So all these things you have to see. Then whether the drug is effective or not, ART is effective or not. So all these things, if you see, definitely it will release these infections.
Yes, sir. This was finally sought by us, a group of dermatovenerologists at Osmania Medical College. We have concluded with this. That was a case of Bovinoid papulosis with molluscum contagiosum. See, one should not miss out coincidental. This Bovinoid papulosis, as you all know, is a pre-malignant condition. This all we have to be very, very cautious about this pre-malignant conditions or a coexistence malignancy in a situation of when a patient is on heart therapy as well. Suppose it doesn't respond, what next, what best could be done in this situation is also very crucial. Then the second case, because time is less, sir, we have to rush up. Yes, sir. Now this is very interesting, sir. May I request all of you to kindly concentrate on this case, as we have seen that Neta sir has been insisting on the circumcision. The previous speaker had been very pioneering effect of circumcision on the male genitalia, and this is what we are seeing. What could be the probable diagnosis, sir? Very interesting, sir.
Very, very interesting, but immediately we say it is warty lesions like that. I think
very true.
Smegma getting collected and solidified.
Yes. Why did you suggest a smegma as a differential diagnosis here, sir? What made that?
Might not have cleaned the area after retracting, and it is there, for quite long time. It will be solidified and it will be seen like this. That is my
perfect, sir.
And it
is true, sir. Yes, that is true.
I agree with Elango one that it could be one. The other one is mistreated viral wart. Not been properly treated viral wart. The first one I would go for is to an unhygienic person who has not cleaned his prepuce and the corona properly, so that it has smegma has solidified and become discolored also. That
excellent
would be my
co-factorization of.
Just try to remove it and see what happens.
Dermatosis neglecta. Dermatosis neglecta.
Yes, sir.
Yes. Now, the situation of COVID must have compounded the cleanliness so far as that lesion is concerned. But generally, we are reluctant and we go about diagnosing a case that it is a condyloma acuminate at this, and so we start treating a case. My request to all the the postgraduates who are observing this is to always have clean the area at the preputial or a preputial sac, and then go about diagnosing a case. Thapa sahab, aapka kuch suggestion? Thapa sahab, aapka kuch suggestion? Any suggestion from Thapa sir about this case?
I think this is a dermatosis neglecta only. It's just a smegma which is collected there. He may not have cleaned the area. After I clean that area, only then I will think about other possibilities. So if it is not removable or it is a adherent or something, then probably we have to thought about, could this be some kind of a malignancy or warts? Those are the possibility will come. Right.
Now, I would like to highlight the panelists that is a 17-year-old male patient with these 2 months. There's no history of exposure. And
if it is there for a quite long time, it will be sticky. It can't be removed easily like normal smegma. It is somewhat difficult to remove that. You have to soak and remove that. Not just like other smegma. It won't be cleaned that easily. So you must be very careful while removing that. There may be mild bleeding, maybe there, because it will be sticky.
Yeah. There may be some kind of irritation, some some irritant dermatitis or some infection could be there underneath also.
We don't know how long he has cleaned that area. Right.
Yes, sir.
Sir, would it remain asymptomatic for so long?
True. This is all permutation combinations I want in a panel discussion, because the entire nation is on an interesting topic of this. This is what happened, sir.
Yes.
Happened after cleaning that area.
Yeah, if it is
That
already secondary infected, you might have visited the hospital quite some time back. Since it is asymptomatic,
that's a point, but not necessarily. We'll come across some more such phenomenal things in the next slide. Sir, this is very interesting case. The patient came to one of my colleague. He referred it to Usmania General Hospital, where my PGs were stunned to see this case. They thought, sir, what is this? This appears to be condyloma acuminata and all that. And it was something like funny situation. What to do with this case? Then we asked him to go and get it cleaned. Once he came up with this, then we were all rest assured that it was smegma.
Yes.
That was very thrilling case, sir. The last 3 decades, I haven't seen a case having stuck up of smegma for 2 months.
Excellent case.
Sir said that is it possible that a patient with 2 months having without any absolutely nil symptoms, is it possible? But here is the case where absolutely nothing happened to that boy. As Betkarur sir said, probably COVID must have contributed to the magnifying of this situation, though not irritability or something. He was very silent. He was docile. He did not do anything, manipulate with that area, thinking that maybe he must have thought it is also a coexistent COVID condition. So probably he would have kept quiet and came to us, to Usmania General Hospital, where we had to get that thing removed and come to a conclusion that it was just a smegma. I mean, it is confirmed by the presence of an uncircumcised penis. The significance of an uncircumcised penis is important. Yes, sir. Case 3. We have a case 3 like this. Yes, sir. 70 came with these lesions. It's 1 year duration. History of pain and burning present associated with occasional bleeding. There is no history of exposure, sir. Obviously, he's 74-year-old. But that doesn't rule out STD, please.
Raju, can it be erythroplasia of curate?
Sivaram Reddy, sir, very perfect.
Erythroplasia of curate, one
Yes,
of the differential diagnosis.
True, sir.
Other possibility, first possibility should be plasma cell balanitis.
Yes.
Okay, that is also because of accumulation of this smegma only.
Extraordinary.
Extraordinary. So that can produce both the sides. So that can produce like this, and it's also thought to be the cause of predisposing cause to the lichen sclerosis. It may and it may be early stage of lichen sclerosis.
Wonderful, sir.
So that is also possible.
Wonderful, sir. Wonderful, sir. 71-year-old.
Circumcision and biopsy will confirm the diagnosis. Circumcision.
Good, sir. We'll move to the next slide, sir. I mean, the consecutive slide of this. One more slide is there. One more slide, sir. Now, sir, see. The same patient, this is the first picture. He had smegma accumulated there for please. See the significance of circumcision, which was told just 15 minutes back, is reflected in my slides.
Yes.
It was not randomly discussed with Neta sir that I'm going to place this slide. It is so coincidental and so fortunate is this organizing committee people that we have incidentally got this case.
No, that need not be circumcision need not be stressed. Only
the smegma, the presence of smegma in a 71-year-old for 1 year, he did not bother to clean. And then when he came here, we asked them to clean that. And that is the circumscribed picture, what we are getting here. As Elangovan sir said, Papa sir said, this smegma is contributing significantly to a pre-malignant condition, or maybe will land up into malignant once we do a biopsy.
It can, yes.
Thanks for that eminent panelists who have been so precise in their pre-diagnosis of a smegma, creating a situation like this, which I later posted you in the picture. Thank you very much, all the panelists. So good, so efficient they are.
So was the biopsy done from the lesion?
Biopsy, we have yesterday he came, sir. Yes, that's what I'm telling. It is so coincidental that it is so coincidental that Mehta sir has suggested circumcision, and that is the case we have. So these are the differential diagnosis sought.
You are doing a biopsy or circumcision?
Yes, sir. No, sir. We are first going to do a biopsy and then plan for a circumcision. And ultimately,
no. It would be much better because the lesion is on the prepuce. Why don't you do a circumcision itself and take a biopsy?
Correct. That is also a very good suggestion.
Yes, sir. A better option instead of
better option. True.
instead of this,
No,
it will act as a
71-year-old.
therapy and also diagnosis for you.
True, sir. That was true, sir. That is a
Ah.
very good suggestion, but a limitation of a patient of 71-year-old and in a COVID
71
situation.
is much better for you to do if he is not a diabetic or doesn't have a constitutional any other comorbidities. Go ahead, do a circumcision and then biopsy. So you can just put him that this could be a case of cancer. So you are ruling it out.
Is there any bleeding on touch, Dr. Raju?
There was mild, there was slight amount of bleeding was present in that case when he retracted the pubis, because as you all know, there was a phimosis situation, having smegma underneath and the smegma contributing to phimosis and then the development of an inflammation there, compounding the phimosis at that situation.
Another important differential diagnosis is candidal pyelonephritis, as you all know.
Very true, sir. Very true.
Which also should be done.
Perfect, sir. Yes, yes. Yes, obviously, the other aspect being anti-prostatitis, though he was not a diabetic male, but yet we have to, the first instance, in nail case, maybe a case of candidal prostatitis, we have to go for a blood sugar investigation. Then the case 4. I know it's a little difficult, but an annular lesion.
Presenting with burnings. LP, I think.
Very true, sir.
Presenting with burning sensation.
A burning sensation. Yeah, he had a burning sensation for 1 month. Anything else, sir?
STI, non-STI. I would like to go for a non-STI rather than STI.
So history of bleeding with Dettol and other things, irritants.
Yes.
So that is
not there. Not there in this case.
Okay. So.
I'm sorry, sir. I'm sorry. I'm making you all to think twice before we discuss this, because I'm sorry, but I had.
Can you tell the lesions? The
tricky, but to make it tricky and more tricky, I want.
Yes, yes.
Yeah, I can say the inflammation and the rim of the glands and rim of the prepuce.
There is lichen planus.
Possibility
of lichen planus.
Possibility, yes, sir. Possibility.
LSA also could be possible.
LSA.
Very good, sir.
Any history of sexual exposures also should.
No, not there. Not very much there in this case. No, he denied history of exposure, sir.
Are you not once again showing smegma? Smegma
the threat of smegma is lingering large.
That is also possibility.
Yes.
But why should it be well marginated? That is the question. No, it is a well marginated lesion on the glands. So I would definitely go
there is
for
some
non-STI.
There is some
a LP or a psoriasis lesion there, unless of course there is no maybe a treated case of one of these two. One otherwise a 24-year-old male would be my first one.
Drug induced.
Unless it is a hyperpigmented one, I would have even thought of FDE also in this case.
Does he have some psychological issues along with, which may be causing problem?
Maybe, sir. Maybe
he is habituated to masturbation.
Very true, sir. Very true, sir. Very true. Yes. Very true, sir. Sivramani, sir. Correct. Yes.
What is the relation between masturbation and this?
The case of traumatic.
Trauma. Okay.
Probably, sir, wants to diagnose this case as a case.
But that would be more near the frenum, I think.
We did see cases in the anterior aspect, I mean, the dorsum of the glands. We have seen few of the cases which have annular lesion and erythematous lesion in the 12 o'clock lesions, or maybe between 10 and 12, maybe between 10 and 2. We often have seen cases of, as Sivram Reddy sir said, that a traumatic pyelonephritis can be there, and then subsequent application of, because of apprehension of having developed some infection, a venerophobic condition situation where he must have applied subsequently and then must have got a case of pyelonephritis with us. So that
possibility of application of some irritants and something like that.
Correct, sir. Correct, sir.
So
much likely
because that will produce maceration also and ulceration.
Also, yes, sir. Yes, sir. Yes, sir. Yes.
Is there any hirsutis papillaris there?
It appears, sir. There appears to be hirsutis. Yeah.
Appears to be.
Yes, sir. Yes, sir. Hairy penis. Yes. Yes. There are some lesions. There are some
congenital.
what we sought for. So far as differential diagnosis, infective, it is bacterial Belnoposthitis. As Sivaram sir said, maybe a trauma and maybe a Belnoposthitis and subsequently the fuse of spirochetes and a situation. Then gonorrhea was also sought to be considered for differential diagnosis. Chlamydial infection, HSV Belnoposthitis, and non-infective being traumatic FD, irritant Belnoposthitis, Zuhn's Belnitis since it is on the glands, Circinate Belnitis since it is on the glands, and a squamous cell carcinoma in situ.
Sorry to interfere, and a question about gonorrhea causing Belnoposthitis.
Very rare.
Highly questionable.
Improbable. Yeah, improbable that is. Yes. True, sir. True, sir. But the differential diagnosis thought was this.
Okay.
All this
Long
needs
list
to
of
be, yeah. Now the case 5, sir.
But that case was managed, or it is still a,
No,
Yet
what
to
was
be
the
diagnosed,
final
we are thinking provisional diagnosis to be LP only, sir.
LP?
okay. What was it?
Consider
Has
here,
it
but
been
we
treated now?
considered on
No.
paper that it is a case of lichen planus only. And
Okay. Has it been treated? Means
no, sir,
what
no,
is
sir,
the-
no, sir. This of late these cases have come. We have straight away.
Sir, one more thing I could ask you is like something congenital diabetes.
No, sir, no, sir.
They may be causing some cuts and other things and getting burning sensation.
No, sir. He was non-diabetic. That aspect we have ruled out.
Yeah. Okay. Okay.
Next
Thank
case.
you, sir.
Yes, sir.
Thanks a lot.
Now this is very interesting again. RVD positive, inguinal swelling on the left side for 2 months.
Tuberculosis.
But
The profuse
LGV,
can be
tuberculosis, and
the profuse can be retracted.
groove sign.
Yeah, it looks
There
like
was no ulcer there.
very
There was absolutely no ulcer on the prepuce. Prepuce was absolutely perfect. No erosion, no lesion on the glands whatsoever in the history.
Okay.
Ravi, it can be
I don't think so.
venereum with a transient
Could be LGV and tuberculosis as one of the differentials.
So
Other
what
could be some non-Hodgkin lymphoma.
Excellent, sir.
If it is, was he HIV positive again?
Yeah, RVD positive. Huh?
Other areas, whether its lymph nodes are enlarged or not. Hello?
Yes, sir. Inguinal swelling it was. It was mass present on the left inguinal region. That's all.
The groove looks like as if it could be.
That was a
LGV.
deceptive case. Hence I posted in the group. Hence I sought for your
But
esteemed
skin
explanation
changes
in the
are
panel.
not there suggestive of anything. So of LGV, skin should have shown some changes, inflammatory changes, but it is not seen. So probably a cold abscess. As Rakshmikant said, it could be tuberculosis, and as Dr. Thapa said, unless of course there are other lymph nodes in elsewhere, maybe abdomen, maybe somewhere else, then we could, since he is an RVD positive patient, so non-Hodgkin's lymphoma can also be thought of. So a bit deceptive. Of course, absence of skin, ulcer in the genital area rules out quite a good number of one. I don't know what it is, VDRL. What the VDRL was.
Yes, sir. The next slide, please. Bhumesh.
LGV means the abscess might have been formed within 2 months.
This was the differential diagnosis sought.
Yes. No, lymphogranular venereum, the abscess, multilocular abscess might have been gone and the sinus formation might have occurred.
And it should be bilateral also, lymphogram.
Correct, sir.
Correct. Transient ulcer could be one of the things.
Except a transient chancroid, other
chancroid, maybe a transient chancroid must have occurred and then gone, and then this.
Very unlikely.
Very unlikely, sir. Very unlikely.
I was surprised to see whether hernia is one of the differential diagnoses.
Correct, sir. Correct, sir.
I don't know whether,
perfect.
Unless you give us some history, you know, that whether it was reducible or not reducible.
No, it was not reducible, sir.
Tender or non-tender.
Sir, this case, it was a non-reducible swelling.
I don't know why you put pseudobubo, because lymph node is enlarged means, I don't know why you have given the differential diagnosis as pseudobubo. It won't rise at all. We won't think of venereal granuloma at all. I don't know why you have given that, because there is no lymph node involvement except secondary infection and the ulcer in the genitalia and the secondary infection. So I think that can't be, it's not applicable.
True. The suggestions I wanted. The suggestions from the esteemed panelists I wanted for the entire nation to hear.
No, we have to palpate it and find out it is a farm, it's
Yes, sir.
painless.
The approach. The trick is the approach. The trick is the approach to such an inguinal swelling. What all can be done in that situation?
I would approach this in this fashion. I would do a FNAC. Okay. Definitely. First is an FNAC. Probably go for an ultrasound in non-invasive if at all we need. Two things. Then depending on the report, yes, and of course the other routine investigations which can indicate something of
FNAC.
some towards some disease. Instead of opening it up with any other thing, I would definitely put a needle for FNAC and see what happens. After that, we will go ahead and depending on the response, depending on the reports, we go because he's a RVD positive, probably he must be on ART as of now. So we'll go ahead with that thing. Only after that, and
would like all the postgraduates to concentrate on this. What Dr. Bedkarur sir is telling, what Elangovan said, what sir has said about a differential diagnosis of a swelling in a RVD positive. Please, the next question, the next case.
Non-Hodgkin's lymphoma.
Yeah, sir, that was considered as a differential diagnosis. True, sir. Sivaram Reddy, sir. Yes, the next case, sir. 25-year-old male came with itchy lesions of penis for 1 month. History of exposure denied. That is how the lesion is again.
I think you'll have to give us something more to think about.
This is more look like a lichen planus.
Correct, Tapasa. Excellent, sir. Very good.
Annular lesion.
Annular lesion, correct.
LP or psoriasis looks like a little bit scaly on the surface. So
sir, could you suggest a trick in differentiating between psoriasis and a lichen planus in this situation, sir?
Could be a little bit of scaling, more scaling in psoriasis, and mostly on the glans.
Malaceous in LP.
Yeah, and little white discoloration. Pointing towards LP.
Going to say again circumcision for this?
Psoriasis will not look like psoriasis as we see commonly in genitalia.
In other parts of the skin.
Because there it will be a well-demarcated erythema will be there. But the lesion elsewhere should be there.
I had seen something like a pityriasis rosea sometime back. It was very, very unusual that time. And I think, this could be one of them. I don't know, probably. Could be one.
Necessarily, we must do a video.
Because once we say rare, it is very rare thing that can happen.
Correct. Yes. I would like to reiterate the fact that all these panelists, for the first time they are seeing and discussing, please. Thanks a lot for all the panelists who have given their best suggestions so far as were concerned. Thank you so much, all the panelists, sir. Now, this is what we sought as a differential diagnosis. Annular syphilis is also considered here. This we have missed.
Itching
annular syphilis lesion should be other lesions.
We did consider. Along sir.
We did consider. The point of itchy.
Correct.
Itchy lesions means we won't think of syphilis. So, anyhow, whatever the lesion is, you have to do VDR. There's no doubt in that. But since it is itchy means we will give the wrong information to the postgraduate.
Alangavan sir is absolutely correct. Any condition which is coming with a genital,
you have to do.
But clinic, inevitably we are going to do a VDRL, sir. Yes, true, sir.
Itchy, yes. You can somewhat not think of syphilis. Don't think about
subsequently, yes. Though it was considered as a differential diagnosis, necessarily we must consider in all those lesions, which have annular picture, especially on the glands and all, we must consider. This is how it was treated. With the annular LP, treatment was started with topical calcineurin inhibitors. Next slide, Bhumesh. Bhumesh, sir, next slide. Yes, case 7. Now this is an interesting again.
Oh. There are asbestos-like scales.
This is more look like some kind of irritant he has applied. Okay, so and it is a post-inflammatory scaling which is coming up. It is not mycaceous that
mycaceous balanitis.
No, it's not like that. That should be more thick and hyperkeratotic in nature.
All the postgraduates to concentrate on the discussion, please. The eminent panelists have been discussing
I would
these
definitely
issues.
agree with Dr. Thapa about this. I think this fellow must have cleaned it with Dettol direct. That is the most commonest one. That is how they do, especially if they have had some, either they have masturbated or they have had sexual contact. That is what they do, direct Dettol.
Examination.
That was the provisional diagnosis sought, genital psoriasis.
Okay.
Allergic contact dermatitis was ruled out, VDL was done.
Oh, I think you could have just managed with, see if the...
With the emollient.
Yes, sir, that's what we did. We started with topical steroids, but you were not responding.
See, if we are talking in terms of to VDRL test and other things, and as Thapa said, we are looking at an irritant dermatitis, I would have just used a topical steroid instead of vitamin D analog, or just cleaned it with just gentle wash for a period, 1 or 2 days, and then gone for a mild steroid, mid-potent or mildly potent steroid, and done that. And instead of going for a vitamin D analog, which is specific for psoriasis, that would be a better option rather than going for a vitamin D analog for this.
Thank you, sir. Thank you. Thank you for the excellent session. Thank you, sir.
This is SY2, I think.
Thank you, sir. This is the next case. Exposure present, sir. Now the trick here.
Rheumatoidal type of secondary syphilis, I think.
Secondary.
Excellent, sir. First DD, perfect.
This could be reiters also.
Writers could be
Excellent,
one
sir.
thing.
The reiters, rheumatoid syphilis. So the but lesions,
Yes.
psoriasis
Excellent,
also.
excellent, sir. Excellent, sir.
Excellent.
Excellent.
Other areas of the body.
Yes, sir. We'll show the next slide. Next slide, Bhumesh. Yeah, now see.
Look like reiters, more look like reiters, or maybe papular psoriasis. I don't know. Papular lesions are not there, but more look like hyperkeratotic type of lesions. I don't know what about the joint involvement.
Rheumatoid psoriasis.
So if you are giving the history of, prominent, that history of exposure is there, and that to a 34-year-old male, then the first thing that comes to mind will be, I don't know whether he is a retroviral positive. And
No, sir. No, he's not positive. No, sir.
Not. Then the first
because
thing that
if
comes
had
to
he
mind
been there, would have displayed here.
will
No.
be syphilis. But if the history of exposure was not there, then the first diagnosis would be psoriasis.
Okay.
If the history suggestive, giving the history of exposure 3 months back was not there, then first diagnosis would be psoriasis.
So if you are thinking of, sir, if you are thinking of malignant syphilis, whether patient is toxic, toxic or not, patient having fever and other things or not.
Quite possible, sir.
Loose maligna will be a little difficult.
Toxic, yeah, it will be toxic, and you won't be able to move around and all, and the rupial form will be there. And I don't think so. It may not be.
Was VDRL negative in this?
VDRL negative, sir, in this case. Yes, VDRL was negative in this case. Hence, we confirmed with VDRL, since VDRL was negative and there was no ulcer present, then histopathology was done, a biopsy was done, then clinched the diagnosis of psoriasis, labeled it as rheumatoid psoriasis, started him on methotrexate.
Okay, right.
Next case, case 9, please.
Oh, kissing ulcer.
Kissing ulcer, sir. History of exposure present.
20 days back. So, could be
If,
primary
chancre must be the diagnosis.
It's a kissing ulcer, so possibly. And there are two.
I think it is indurated, painless, probably.
Yes, sir. Next slide, Bhumesh. Yes. This is what was considered for differential diagnosis. He said, sir, primary chancre, chancroid since auto-inoculation, since kissing ulcer. Herpes genitalis also was sought. Donovirus was also considered. Then
Donovan is
we
possible.
consider traumatic because it was near the frenum.
I don't know why FPV was considered in this case. Such an indurated, almost like a edge of the ulcer is not suggestive
Dr.
of
Singh,
FPV.
we are cutting close to time, 5 minutes away.
Yes, sir. Yes, sir. Sir, VDRL was 1 in 16 and the case was treated.
But this case was based for dark field
Sir,
microscopy.
correct. We have recently spoiled our dark field, so we could not do a dark round examination, sir. We are sorry. But VDRL did confirm the case that it was a case of primary chancre. And then we started him on directly on benzathine penicillin. And this is case 10.
It was excellent case.
Correct. Sir, we are running short of time. Sir, now this is
secondary.
This case.
Is okay. Syphilis.
Now, what is non-STI and what is STI in this?
SY2.
Erythema multiforme.
So far as STI is concerned, then the non-STI situation, sir.
It could be secondary syphilis, it could be lichen planus, it could be erythema multiforme.
Excellent, sir.
Erythema multiforme also could be there. But
correct, sir. Correct, sir.
Bilateral, symmetrical, both sides. So the two possibilities, secondary syphilis and that. But one is asymptomatic, other will be a little
next slide.
have symptoms.
Next slide. Excellent, sir. Next slide. Yes. Now this is the differential diagnosis chart. Palmar warts, erythema.
Warts could not be a possibility.
I don't think warts could be considered.
Could be considered.
And, even palmoplantar psoriasis
yes.
Also.
Okay.
Sir, are you still seeing lot of secondary syphilis? Because in private practice, I have.
No, sir. Many cases have been coming. Sir, next slide.
Hardly any.
Sir, next slide. We are running short of time. Case 11. This is an excellent case, sir. I'd like all the panelists to. We have very short time, but it is very unfortunate that we have got this case at 11.
Nodular scabies.
Scabies.
Nodular scabies.
Nodular scabies.
Nodular scabies. More of a nodular scabies.
Next slide, Bhumesh, please.
Again, was he HIV positive? He had so many.
Yeah. Perfect, sir. Perfect, sir. Perfect question. That is the trick. That is the trick. That is the trick. He was positive. Next slide, Bhumesh. Next one more slide. Now see, sir. This is.
Oh, yes.
Pictures of the same patient?
Pictures of the same patient.
The last picture is similar.
This could be secondary syphilis also.
This is a case of secondary syphilis. True, sir. This is perfectly a case of secondary syphilis.
Yes, secondary syphilis.
A nodular lesions in the glans penis and a nodular papillonodular type of rarest of rare presentation of syphilis. We did get case. He's the child positive. He's from Telangana, Armo district near Nizamabad, where this man hails from. He misled us saying that he's married 3 months back and then came up with all these lesions. We were really bewildered to see what is this going on. We had a nodular lesions in the glans penis, denied as such a history of exposure, said he was married. Then he had all sorts of lesions of papillonodular to consider this nodular lesions as the scabies and then to find lesions on the body and all. It was rather a more confused picture for us.
What about itching, sir?
Itching was there in this case, sir.
Sometimes in HIV positive patients, you may find itching could be there.
But itching is more of a subjective phenomenon.
Yes. Next slide, Bhumesh.
Follicular syphilis has more.
This is the same case, sir. He had lesions on the face, see, sir.
Oh my God.
Oh.
Superant, yes.
This
typical that papules, that papule and all you can see, sir. The angle of the mouth, you can see.
Yes.
Split papules.
Yeah, you can see the split papules at
Now
the
there
corner,
is
angles of the mouth. You can see them, sir.
Right.
And the VDRL was 1 in 256.
Wow, it's too high.
The papillonodular syphilis, although less common, sir. But
was he given penicillin?
Yes, sir. He was given penicillin.
Benzathine penicillin.
Did come down. VDRL did come down.
And the lesions
There
also.
was no any other reaction post.
No, sir. No, sir. Absolutely safe.
Jarishak's
Yeah.
No, sir. Not there. Not there.
That could have been there with such a high.
It was incidentally, fortunately, it was not there for us, sir.
Okay.
Good. Excellent cases, sir.
This is all what we saw in the last fortnight at Usmania Medical College. I am posting before you, sir. Next slide. We have running short of time. Case 12. So we'll make it fast.
Yeah.
Next slide,
No,
Bhumesh.
no. These are ulcerative lesions which are there.
History of exposure denied.
Ulcerative. Yeah,
Recurrence
ulcers.
present. Recurrence present. The redeeming feature. Recurrence was present.
Recurrence.
Okay, basets.
Okay.
Oh,
Basets.
extraordinary. Yes, sir. Yes, sir.
Recurrent aphthous are the basets.
Next slide, Bhumesh. Next slide, Bhumesh. Next slide, Bhumesh.
No problem, sir. We can take 5 minutes extra.
No, Bhumesh, I'm concerned more about you.
We have a lunch. Followed by we have a lunch. 5
Then
minutes we can take.
Herpes, I think.
Herpes also possibility, but then how many recurrences he is getting? What are the systemic symptoms?
This is what we sought, sir. Herpes. We sought for Behçet's, as sir said, Thapa sir said that there was a sense to consider Behçet's in this case. We also the oral lesions preceding these lesions of the scrotum.
Then the Behçet's.
Yes.
Maybe he is using condom, and that is why he has got a lesions on this thing.
Yes, sir. Now the last case, sir. Case 13. Thanks, Bhumesh. Case 13. No. Obvious case.
Chlamydia.
Gonococcal.
The 2 days.
Morning dew.
2 days.
2 days is a gonococcal only.
Yeah. Gonococcal and
could we have associated chlamydia also? We don't know.
Always coexistent, no, sir. They all go together always. Without saying, they go together.
give gray color kit.
Correct, sir. Yeah.
It requires a syndromic.
No. This is odd. We thought
was smear gram stain done for this?
Gram stain has been sent. Okay. Yes, sir. We have sent for gram staining to find out diplococci. Yes. This is.
PGs would be very interested to do a gram stain for this. PG should do a gram stain for
yes,
this.
Sir. Yes, sir. We are always after them. We are always after them to do a gram stain.
And if possible, I think if the facilities are available, you could go for a culture of this.
Yes. True.
Okay, in microbiology. So that would give a better this one.
All the postgraduates to listen carefully to what National President speaks, and the panelists, eminent panelists, have been speaking all along. I need to write it down on a piece of paper, all that, if you can recollect. The syndromic management, the limitation, as the preceding speaker Somesh Gupta Sahab has said, that this limitation so far as using kits in the females are concerned is very, very important. Please, to remember, all the postgraduates remember, this is case 14, the last case, very important. The last case is very important, sir. This is history of exposure denied. Short duration of lesions. Painful raw areas. Is
there any drug eruption? Drug reaction?
Oh, excellent. Sivaram Reddy, sir.
FD.
Recurrent. Bhumesh, please.
Was it recurrent?
Yes, sir. Now this is a confirmatory lesion.
Yeah, FD.
Mixed drug eruption.
This is
mixed drug eruption. You may get all PGs. You must read the fact that FDE can proceed with a mucosal lesion first, especially on the lips or on the genitalia, followed by a lesion independently on the skin. Or you may have an independent lesion on the skin. Commonly, you will have lesions of that sort, but you may also have a mucosal lesion followed by. Thank you very much. Thank you very much for this panelist. Betkarur sir, Thapa sahab, Sivaram Reddy sir, my colleague, my senior, Rashmikant sahab, Alangavan sir. I'm so gratitude. I remain gratitude towards you that you have been so good with me. Especially the national president has been very busy all along, sir. Was very busy. I have seen him in the ascent and immediately he came back here and was dot sharp and explaining very good, excellent. All the panelists have been so good. I'm so fortunate to have such a good panelist. I thank all my organizing co-chair persons, my people. I am extremely thankful to all of you. Thank you very much.
Sir, Dr. Rajesh Singh, sir, Dr. Murugan.
You have conducted very well. You have shown
Very
a
well,
good.
Dr. Rajesh Singh, sir.
Thank you, sir.
Very good cases, Dr. Rajesh.
Thank you, sir. Thank you, sir.
Congratulations for wonderful cases and your panelists. Only one comment I want to make it. That is regarding the smegma. You have focused 2 cases, 17 years and 71 years, and you have even blamed the COVID situation. I want to stress one thing. we have not taught anybody to retract the precues and clean well. They don't know. Most of the patients I have come across, they need not, if it is, there is a phimosis, circumcision is the only way.
Message
I understood.
from the Murugan sir. Yes, sir. Greatest message you have given. Yes, sir.
Yes, we don't know. We don't teach them, our youngsters and other people, how to open, how to clean, how to see the. They never saw the coronal sulcus at all. So in these cases, we have to train the individuals to clean well. That is very important rather than circumcision. Circumcision is, of course, is the indication when there is a phimosis there. Otherwise, very good, sir. Very excellent panel. Thank you. Congratulations.
Thank you. Thank you so much. Thanks.
Thank you so much.
Thank you, Bhumesh, everybody. And I think lunch will be served by Bhumesh.
Yes, sir. Yeah, everything, sir. Whatever you want, you can take.
We are waiting for the Swiggy fellow to come.
Whatever you want, you take, sir. No problem at all.
No, we are already waiting for the Swiggy fellow to come.
Thank you so much,
Thank
sir,
you,
Rajiv
Bhumesh.
sir, for the excellent moderation.
And Hyderabad team for an excellent job. Thanks a lot.
So, as usual, the wonderful case discussion moderated by Dr. Rajiv Singh sir and the very experienced the panelists we have kept for this discussion. Really, all 40 panelists are very excellent.
I'm overwhelmed by all the
lot of
panelists.
take-home pills.
Really.
And not only that, for the faculty, so it's a time to sensitize more on the PGs. I invite Dr. S.B. Kavita, today's the quiz master for this session. She is associate professor from Gandhi Medical College. And over to Dr. Kavita.
Yeah. So mostly the PGs might be waiting curiously after listening to this exciting panel discussion from our eminent panelists and the moderator. Literally, most of the PGs might have learned so many pearls. So it's the time for us for the quiz. So be ready for the quiz. And the instructions are, as you know already, each session will have 10 MCQs, each one correct answer. Mark only one correct answer, sorry. The first 3 toppers will be selected for first, second, and third prizes. And the duration of time is just 5 minutes. Postgraduates has to submit their bona fide certificate from the concerned HOD if they win the prize. And the quiz master decision is final. And also, don't refresh or close the browser. There are exciting prizes. So be in a competitive spirit, start your quiz. So thanks once again, all the panelists. Really, it was really an exciting and have really learned a lot, sir, from all the eminent teachers, in fact to say. And Rajiv sir, the picks are really so good, sir. I'm really missing you in Gandhi.
Thank you, Kavita. Thank you so much, Kavita. Thank you very much.
Kavita, felicitation.
Yeah.
Invite
I now request the chairpersons, Dr. Rajiv Sridharan sir, Dr. Vineet Relhan, Dr. N. Ramesh sir, to felicitate our speakers, Dr. Sumati ma'am, Dr. G. Narsimrao Neta sir, and our moderator, Dr. Rajiv Singh sir.
Yeah.
And I request the organizing team.
Congratulations.
Felicitations as if it's really as if you are attending physically. It means kudos to Bhumesh sir. I now request the organizing team to felicitate our chairpersons. I thank the organizing team for giving me this opportunity. Thank you all.
Thank you. Thanks a lot.
Thank you very much for
Thanks, everyone.
Yeah. Sridharan sir, go ahead.
Thanks, everyone. It was wonderful.
If Rajiv Singh could collect this many cases in a couple of weeks, I can imagine the kind of cases you get there. Thank you. Thank you so much. It was a good learning.
I better send my PGs to Rajiv Singh for 1 year, 10 days training on STIs.
Definitely.
I tell something like, Telangana never stop in teaching.
Thank you. Thank you, sir.
Thank you.
Sir.
Thanks a lot.
Thank you so much, sir.
Always sharing of
for your
knowledge
kind
from all your
words.
people. And a
Thank
special
you.
thanks to Dr. Betkarur sir, in spite of his busy schedule.
Yes.
So he has
Thank you, sir.
participated and he has contributed.
Thank you, Betkarur sir.
Appa sir and Rashmikan sir, Elangovan sir. The excellent
Such a
contribution.
touchy
That's why we
explanation.
kept a senior most panelist in this session.
Senior most. Thanks, Bhumesh. Thanks,
And I
Venkatramana sir.
request
Thanks.
all these panelists be there in the valedictory also.
Yeah, don't make us senior, only senior consultant, not make us senior citizens.
Yeah,
Okay.
senior consultants only.
We
Don't
will.
call us senior citizens.
It's a test for us, and we also learn that we must be update our knowledge every day.
Thank you, Elangovan sir. Thank you so much, Elangovan sir.
Thank you.
Thank you so much. And we are on time. Pre-lunch session, we have finished 12:59 with 1 minute left. So thank you. And we will meet again at 1:30 sharp. So please don't go away. So post-lunch sessions also very interesting and encouraging sessions are there. Please be there and encourage us. Thank you very much.
Thank you. Thanks a lot.
Thanks,
Meet
Bhumesh.
there.
Bye. Bye, sirs.
Bye. Bye.